All right, good afternoon, everybody. Welcome to our latest Talks at 12 for the academic year presented by the Bronfenbrenner Center for Translational Research. And today we are pleased to feature Kate Guastafaro from New York University. First, we'll begin with a land acknowledgement. Cornell University is located on the traditional homelands of the Cayuga Nation. The Cayuga Nation are members of the Haudenosaunee Confederacy, an alliance of 6 sovereign nations with a historic and contemporary presence on this land. The Confederacy precedes the establishment of Cornell University, New York State, and the United States of America. We acknowledge the painful history of Cayuga Nation dispossession and honor the ongoing connection of Cayuga Nation people, past and present, to these lands and waters. You will be able to ask questions after the talk. For those that are in person, please raise your hand. We'll bring you the microphone. That'll allow the online audience to hear you. And if you're joining us today online, please put questions in the chat or the Q&A. We'll monitor them throughout the talk, and then we'll ask them afterwards. We are pleased to welcome Kate Guastafaro, Assistant Professor in the Department of Social and Behavioral Sciences and Associate Director of the Center for Advancement and Dissemination of Intervention Optimization, also known as CADIO, at New York University. She earned a doctorate and master's of public health from the School of Public Health at Georgia State University. She was an assistant research professor in the Department of Human Development and Family Studies at Penn State. Working at the cutting edge of prevention and intervention science, Dr. Guastafaro's program of research is devoted to the development, optimization, and evaluation of effective, efficient, economical, and scalable interventions, specifically focusing on the prevention of child maltreatment. In 2020, she was the recipient of the Victoria S. Levin Award for Early Career Success in Young Children's Mental Health from the Society for Research on Child Development. I have a feeling we're going to take a lot of notes today.
Oh, well, I'm great.
Please welcome Kate Guastafaro.
Thank you. Oh, thanks. Well, thanks for having me. When I start this presentation, oftentimes I just want to give a little disclaimer that this is a totally different way of thinking about intervention development. So I invite you to kind of sit in that discomfort because it could be kind of cool, right? And so I'm going to talk about a translational framework for intervention development, specifically the multi-phase optimization strategy, or MOST. And my goal is to just whet your appetite. There's no way that I could do everything in 50 minutes. So big picture kind of overview here. So when we think about intervention science and the goals that we are trying to achieve, I would argue that one of our primary motives is to build a coherent knowledge base about what strategies work, who do they work for, why do they work, right? We also want to then use this information to develop the interventions that address those things and create public health impact. And then we want to keep making improvements in these interventions over time. Sound reasonable to you, right? Okay, oops, oh boy. So how do we do this? Typically, when we want to develop an intervention, we do something that I call the classical treatment package approach. I want you to tell me if this sounds familiar. But you're going to start through the literature, start through empirical science, clinical practice, theory, and identify every single possible component that you think might work towards the outcome that you're interested in. Then you take all of those components and you package them together into the proverbial black box as an intervention. And then you test it in an evaluation RCT, something usually like a 2-arm RCT, randomized controlled trial, where we're comparing the control condition to this package that you've amassed, right? Sound familiar? Basically, any intervention that we know and love has been developed in this way. So, given that any number of interventions have gone this way, where are we? What have we achieved in intervention science? So if we think about this knowledge base that we've built, when an intervention demonstrates a detectable effect, and if you're so lucky to find a detectable effect, we don't know why, or we don't know how it worked. And when it doesn't work, we don't know why, and we don't know what didn't work. So I'm not quite sure that we've achieved much in terms of this first mission. Secondly, then we're taking this information and creating interventions that have public health impact. Well, all too often, those interventions that we develop are way too expensive, complex, burdensome, and they never actually reach the people that we've designed them for. I think I need to step back a little. And we don't know how to fix those problems without taking things away, and so therefore taking away potentially the things that make them effective. And then lastly, if the idea is to keep iterating over time, we don't know which of those components that we've put in there are producing strong effects and which are weak effects. We also don't know what to do next. We just kind of think, oh, that might be a good idea, and keep thinking, right? Okay, and so that's all right. We have all done this, but what ends up happening, right? This is the schematic I showed you at the beginning. We get to the RCT. The question is our intervention effective, right? And if the answer is yes, then we care about implementation research, where the questions are, is it otherwise scalable? Oh my God, it goes fast. And what if the answer to that question is no? What do? We start over completely. We don't have enough information to iterate. So these are my words, this is my opinion, and I'm happy for you to disagree with me, but I would argue that behavioral interventions are falling short of having public health impact for the reasons that we've kind of just gone through. So what I submit to you is a big what if. What if instead we assessed the effectiveness of individual intervention components in a routine and systematic way? What if we then use this information to manage a trade-off between the effectiveness that we really want and constraints surrounding its implementation? And what if we could consider the place and the local kind of context where we want this to be delivered from the outset? Like, as we develop the intervention, let's think about where it's going to end up. These are my what ifs. And my solution to those what ifs is MOST, the multi-phase optimization strategy. And so this is a framework. It is not a method. You cannot do a MOST. It's my number one thing that I correct. So MOST is informed by a number of different fields. So of course, behavioral science, industrial engineering, health economics, decision science, and implementation science. So all of these different fields come together to create this different way of thinking. Okay, so MOST is an engineering-inspired framework for optimizing multi-component behavioral, biobehavioral, biomedical, or social structural interventions. And I'm just going to say behavioral, but you understand that I'm all-encompassing when I say that. So when I talk about a multi-component, I would bet you that any intervention that you know and love, you could actually break apart into multiple components. So a component for me is anything that could be separated out for study. It might be parts of interventions. So doing some physical activity, doing some coaching, journaling. Those are all components and content kind of things of an intervention. But a component might also be a feature that is designed to promote engagement or adherence to an intervention. So homework between sessions or role play activities, those types of things. And if you want to think about this in a biomedical, biobehavioral, like a MEMS cap, that like counts whether or not you open the prescription bottle that you're using. All of those things could be components. Last type of component that I'm going to talk about are features that are aimed at improving fidelity of how the intervention is delivered. So maybe that's like a different coaching structure or technical assistance for the people who are delivering it. All right. So when we are adopting this mindset of MOST, what we are trying to achieve is intervention ease. Oh, it rhymed. That's a surprise. That's fun. And when I say intervention ease, what I'm asking us to think about is a strategic balance between effectiveness and then these implementation qualities of affordability, scalability, and efficiency. So affordability, meaning that I'm not designing something that is outside the world of being able to be paid for. Scalable means that it can be implemented in the setting right away without the need for ad hoc modifications. And efficient, meaning we're not wasting resources, time, money, whatever that may be. Okay, so to do this, this is the process of optimization. That strategic balance, that is optimization. So just to put this into a definition, that like say you're ever writing a grant or a paper or a proposal wanting to use most, optimization is the process of achieving intervention ease by balancing effectiveness against affordability, scalability, and efficiency. Sounds okay, but you're like, how does one do this? Great, I'll tell you. So this is gonna still look familiar. You're still gonna go through the literature and identify the components that seem to make sense to you. Clinical practice, gray literature, theory. But before we package them together, we're going to subject them to an empirical process of optimization. The results of that process then inform what gets put into that. So that box is no longer black, right? I know exactly what components are going in it and how they are working towards my outcome of interest. The evaluation RCT or the two-arm RCT doesn't go away. It's just that by the time I've got to it, I have a lot more understanding about my intervention and how it works. So to do all of those things I just said, we break it into 3 different phases. And I'm going to give you a high-level overview and then break it down a little bit more concretely in the next coming slides. So 3 phases: preparation, optimization, and evaluation. And the preparation phase is very similar to how we typically do this. We're identifying a conceptual model of how our intervention is hypothesized to work. We're identifying the components that we might want to include. We do call them candidate components at this point because they may or may not make it into it later on. We're doing pilot work, which would be measuring the acceptability and feasibility of our components, refining our protocols, and then identifying the optimization objective. So that should sound new and weird to you, and I will define that for you in a bit. After the preparation phase, we move into the optimization phase. And here, all we're doing is a highly rigorous and efficient randomized trial, but it uses a different study design than that two-arm RCT because our research question is, what components work and how do they work together? So I'll show you the most common design for that. After that process, if we think that the intervention we've arrived at is expected to be effective, then we might go into the evaluation phase, where we would test it against some type of suitable control. If, however, for whatever reason, we think that it might not be maximally effective, rather than, kind of wasting time, money, energy, hopes, fears, everything, moving into the evaluation phase, we would go back to the preparation phase and revisit the conceptual model and how things worked. That bottom line in the figure is called the resource management principle, and that's an engineering concept where you're not going to waste resources to conduct a highly burdensome experiment if it's not going to produce the effect that you expect, right? If you don't think it's going to work, why test it? One other thing that I'm going to highlight to you is if you are, lucky and you get to the evaluation phase and you test your optimized intervention to a suitable control, the top principle here is called the continual optimization principle. And what this holds is that even an optimized intervention can be further optimized. Think about it like this. Your computer, your phone, your car, it gets better every year, every model, right? And so that's the logic we're putting in for interventions. We want it to be faster, smoother, sleeker, whatever it might be in the next version. Okay, so the preparation phase, very similar to things that you've heard before, right? But one thing that we think about a little bit differently is the conceptual model. And so any good intervention scientist has made their fair share of logic models, right? Where we kind of dump everything in these buckets that we're going to do and how they link together. So the same type of thinking, but this is far more precise. So in a conceptual model, you're going to articulate, let's start on the other side, your outcome. What are you trying to do? And then using theory, say, what are the mediators that are going to affect this outcome? And then you design components that are designed to affect the mediators. Rather than saying, here's all the activities I'm doing, here's every possible mediator that might happen. It's that very one-to-one kind of ratio articulating, this is the component, this is what it is designed to affect, and then this is how that will produce the change I'm interested in. So here's this is a pretty complicated one, but I did that on purpose to show you that it can be complex and it could be a complicated process of change that we're trying to work through. So this is an intervention, it's called It Matters, and it was funded by NIAAA, the end goal was to prevent sexually transmitted infections among first-year college students. And to do this, it targets risky sexual behaviors and alcohol use. So the conceptual model articulates the final biological outcome that we're interested in, which is this reduction of STIs, but then all of the things that have to happen in order to see that. So addressing protective behaviors in terms of sexual practices that you might choose and decreasing excessive alcohol use. And so I'm not doing all the theory for you, but it's all there if you want to read it. And then how those different mediators, or we're calling them outcomes here, mechanisms relate to mediators, and then the components that are designed to affect those mediators. Kind of make sense? We'll come back to It Matters. Okay, so also in the preparation phase, right, I mentioned one of the things we do is the optimization objective. And so this is really just your definition about how you will balance effectiveness against affordability, scalability, and efficiency. So like the goal of your intervention. And I have 3 examples here. The first one is what I call the all active components optimization objective. And this means that I'm going to just include the most effective components, irrespective of how much they cost. So stated differently, don't write this down. It's like trimming the fat, right? Like things that don't work, we're getting rid of. And I think that this one is completely underrated. And people are like, oh, I want to think about cost. I want to think about time. But yeah, first, maybe we could think about like just eliminating things that are not effective. So nothing wrong with that one. But say you work in a clinic or some type of setting where there would be a time parameter, like a classroom. I need to design an intervention that can be implemented within a specific period of time in order for it to be used. So for example, I might choose to identify the most effective intervention that can be implemented in 45 minutes or less. If I do all of this work to develop an intervention that's super effective, but it takes 3 hours to implement, how's that going to work? It won't. So we build that parameter into the design. Same thing with money. If you are lucky enough to know how much somebody might pay to implement your intervention, like think insurance or some other type of care, you can build the intervention around that parameter. So like $500 per person, $300 per person, and build that into the identification. Okay. Then we move into the optimization phase, and this is where I will get excited. So like, just like flag me if I need to slow down. But here, like I said, the goal is to experimentally test your components and how they affect your outcome of interest independently and in combination. So to do this, we use a different type of experimental design, not the 2-arm RCT. These are all up at the top of the figure, members of the factorial experimental family. And then the type of experimental design, so that's on the top, but we also have to think about the type of intervention that we're developing. So on the left side, there are different types. One is a fixed intervention. This is the type where every participant gets the same level of intervention. This is what you normally think about. But then we can think about more adaptive interventions, where the intervention that I receive depends on my performance at a priori specified times. So best example is like school and kids needing a little bit more support as the year goes on. So think about reading. First couple of months, I'm really struggling. And then at 2 months in, you're like, oh, Kate needs a little bit more support. So I get an elevated level of intervention. That's an adaptive intervention that changes over time. So you can have less intense adaptation like the one I just described, or you could have ones that are happening in real time every minute based on what I do. You can think about your phone, like your watch, when it's like stand up and walk. That's more like time sensitive. Okay. So what this figure does is match the type of intervention that you're developing with the experimental design that you might choose for your optimization trial. The bar, like where the bars are darkest, is the best match. So if I'm developing a fixed intervention, the best match design is a factorial experiment. There's a delay, I'm sorry. And I'm going to focus on the factorial experiment specifically, and I will share some resources at the end if you are interested in adaptive interventions. So the factorial experiment is not the same as MOST, right? So Linda Collins, who developed MOST in this way of thinking, did not develop the factorial experiment. That's real fun for her. It came from Fisher, like it's agricultural, it's not Linda. So the factorial experiment in this situation is appropriate for when you don't know what's working, you don't know what could be removed, you've got constraints, time, money, personnel, whatever it is, and your goal is to create a package, like an intervention that's suitable for the average group of people. Okay. So same thing at the top here. This is a figure of what the experiment would look like. So let's say this is the 2 to the k factorial experiment. And 2 to the k tells me that I have k factors, and each of those factors has 2 levels. So 2 is the level, k is the factor. And those factors could come in any different parameter that makes sense for you. On, off, they get it, they don't. Or low intensity versus high intensity. It could be online versus in person. It's whatever levels make sense to you. And I will just say that it is possible in this design to have more than 2 levels of each factor, but your sample size increases by at least double. So we often just try to shy away from that. And more often than not, if you come to me and you're like, I've got low, medium, and high, can you really tell me the difference between low and medium? No. So I try to push folks to think about the 2 levels. Okay. So this table, I have got 4 factors, A, B, C, and D. Factor is the same thing as component. Okay. So that took me like a really long time to realize. But it's just moving into the experimental design versus the intervention design. So in this case, I've got 4 candidate components that I'm testing in a factorial experiment, each of which has 2 levels. So a 2 to the 4th factorial experiment, I get 16 experimental conditions. Are you freaking out? Sounds like a lot. Okay, nodding, yes. Now, if you had 5 factors, 2 to the 5th factorial experiment, you've got 32 experimental conditions. But what that represents is every possible combination of those factors. And so when I enroll folks into my study, they will get, an individual would be assigned to all possible combinations of these different things to come together. a person who's randomized into experimental condition 8 is getting only factor B, C, and D. Whereas somebody who's in experimental condition 13 is only getting A and B, right? Okay. I'm gonna come back, I think, to the factorial experiment, but want to say that if you're like, this seems crazy, it's not. People have done it. And what you're able to estimate, right, is the effect of factor A. So it's comparing everybody who didn't get it to everybody who did. And then all of the other combinations that come along with it. So that's that like advancing science part of intervention development. Okay, so optimization phase, we get through it. We've done all that trial. And now we can move, we think it's going to be effective. We can move into the evaluation phase where our goal is to confirm the effectiveness of an optimized intervention. Typically that happens through that 2-arm RCT, but not always. We ran what we called a hybrid evaluation optimization trial. And I'm going to show you what that looks like in a second, but want to tell you the differences between the RCT and the factorial experiment because it's a different way of thinking. In an RCT, if you end up with a small n per condition, you're like, oh no, we don't have power. We can't look at what we wanted to do. But in a factorial experiment, having a small n per condition is actually not a bad thing, and it doesn't indicate power. The reason for that is because of what we are estimating. In an RCT, we are doing a direct comparison of means of experimental conditions. In the factorial experiment, we are estimating main effects and interactions. So rather than like a cell mean comparison, we're going more in the column direction. So fundamental differences. In the RCT, we are trying to compare usually, hopefully, a small number of experimental conditions. We estimate our effects by comparing the means of individual experimental conditions, and then each participant is only contributing to an effect once. Whereas in the factorial experiment, our goal and what we're trying to do is estimate the main effect of each factor and interactions that involve more than one factor. So if you had 4 factors, I'm going to estimate all the way up to the 4-way interaction of those factors. The effects are estimated by combinations of experimental conditions rather than a single cell. And because of that, each participant contributes to multiple effect estimates. So the participants are used really efficiently. So this hybrid evaluation optimization trial that we did. So it's for It Matters, the one that I told you that's designed to reduce STIs among first-year college students, the intersection of alcohol and risky sexual behaviors. So we published this paper, and what we did was basically a 2x2 factorial experiment, where we still were able to compare the effectiveness of our optimized It Matters intervention versus a suitable control, but we added another factor. Here's where it's exciting. Why did we have to do that? Because we learned when going to scale this up, colleges wouldn't, kind of adopt It Matters if it didn't have a sexual violence prevention piece. So rather than just like saying, hope it works, let's tack it on, we tested it. And so we could see if that sexual violence prevention program on its own worked and how it worked in the presence of It Matters. Smart, right? I think so. So I pitch to you that that falls under this terminology umbrella definition of a translational framework for intervention development. And so there's been any number of these frameworks that have come up, and they at face value all share a similar goal of advancing the empirical process and moving from basic science to translational research. But these frameworks differ in very meaningful ways. And how, if you are an intervention scientist or an early career person that wants to use this, how do you pick which framework to use? Well, I wrote a paper trying to help you figure out how to make this selection. And affectionately, my co-author Angela and I call this the Battle of the Frameworks paper, but it's not a battle because I believe that it's not so important which framework you pick. Obviously, I'm very biased, right? I think most is the right one, but it's more important that you use a framework in intervention development rather than like kind of not having a systematic approach to this process. So in this paper, we compare the NIH stage model, which is at the top, which probably many of you are familiar with the Medical Research Council. Is that right? Yeah. MRC framework, which is largely prominent in the UK, with the ORBIT model, which is the obesity-related behavioral intervention trials that was put together through big group at the NIH, and MOST. And what I tried to do here was kind of anchor them all together so we could have some commonality with the language. There's a lot of overlap, and I think you can see that it doesn't quite matter which framework you choose. You're going to end up at a similar place in terms of translation, but the process of how you get there really depends on which framework you pick. So why should you pick MOST? Well, if I haven't sold you yet, using MOST, unlike MRC and ORBIT, it's able to engineer an intervention that meets very specific objectives and constraints. So we think about development in terms of hitting a clinical benchmark, but then it has to be able to reach the people. So this is what MOST offers that's different, thinking about best expected outcomes in terms of money and time. And so I think that MOST definitely is this innovative new approach to intervention development, and it has the potential to hasten or speed up the progress from basic science to seeing public health impact. I want to be cautious to say, though, it still takes time, still takes a lot of money, but we have a lot more information through that process. I'll learn. So now I wanted to just kind of showcase the way that I think about this and how we could apply MOST to my substantive area of expertise, which is the prevention of child maltreatment. And so this is a walkthrough of, you can read more about this in a chapter that I wrote, but basically here's my premise. Child maltreatment is a public health problem. It's high burden in terms of prevalence and also economic and lifetime burden costs. And the prevailing prevention strategy is home visiting programs. The US government has invested more than $2 billion in the provision of home visiting since 2010, which is great. However, the evidence for those programs that we've invested $2 billion in is not real strong. Like we're lucky if we have like maybe a moderate effect size. But more importantly to me is that those who are at greatest risk are not receiving those services because the services take years to deliver. And there are still way more people, way more children and families who are determined to be victims. So I see this as ample room for improvement, right? And I think there's 3 ways that we could think about improving these interventions that we've invested like so much money in. And we can show you how to make them more effective, how to increase engagement, and also fidelity. So I'll walk you through this one. This is my idea. This is hypothetical, okay? How I would construct an intervention and then test it to ultimately reduce the risk of child maltreatment. And maybe this is recidivism, like so not coming back into the child welfare system or something like that. So that's my outcome. I'm going to reduce the risk for child maltreatment. And in order to do that, theory, science, all the things tells me I need to increase knowledge and skills of that parent. And I also need to change their social norms about parenting behaviors and things like that. So to affect their knowledge and skills, I'm going to address stress management, home cleanliness, and unintentional injuries. So I design a component, a problem-solving worksheet, which is designed to target stress management, an environmental scan that targets home cleanliness, and a home safety component that is designed to reduce or prevent accidents in the home, which then would reduce the unintentional injuries. To create or affect social support, I'm going to build a component about group connections. Okay, but what's cool about my model, if I may say, is that they've got this constant component. So I'm taking the home visiting programs that we've already invested all of this money in and adding to it, enhancing pieces of it that I think are missing to increase the effectiveness, right? Okay, I won't walk through this one in such great detail, but this is a similar, like say I wanted to just improve the engagement in home visiting programs. That's a whole other problem. Like very few families actually finish the program that they're meant to do or what they get assigned to because they're too long or there's too many other demands on their time. So could I design an intervention that is targeting the number of home visits or sessions that they complete? So this is another way that I could think about building an intervention to do that. Lastly, thinking about ways that I might want to improve implementation fidelity. And here I'd be focusing less on the family themselves, but more on the caseworkers or the people who are delivering the intervention. And, you know, just by way of example here, some things I'm thinking about would be training format, certification process, the level of supervision they get, and networking between facilitators. So this would be an intervention designed to improve the fidelity of the people who are implementing the home visiting program. Okay, so again, why most? If you are like, this sounds crazy, who would ever do this? Well, more than 250 projects have been funded by the NIH to do this. And this messy bar chart shows you the level of funding awarded to projects using most between 2016 and 2021. It's a 400% increase during that time. So most is still innovative, but it's something that NIH is investing in. But we've also had projects using most funded by the USDA, Department of Justice, and IES. So education space is big for this as well. And it's worldwide. Some great colleagues in the UK and Netherlands and Denmark, Australia, lots of places using this. So, like I said, I can't do everything in this time. I wanted to create a lot of time for questions because I hope you'll have some. But directing you to some resources. So I am the Associate Director of CADIO at NYU. And this is really like the home of most, that big framework and thinking. But we have a sister center, the University of Michigan, the D3 Center, and they focus on adaptive intervention designs and adaptive experimental designs. So if you are thinking about adaptive interventions, they're your place to go. So we've got a couple books, like literally the textbook on most. And I think like it is complicated in a different way of thinking, but I do think those books are fairly accessible in terms of how they're written. They're not super technical. And then we have a freely available Coursera course, which it follows this book pretty strongly. And it would give you everything that you would need to write a grant using most in your own work. Freely available. You can pay for a certificate, but you don't have to. And we offer a synchronous training that kind of gets paired to the online Coursera course twice a year. And that gives you an opportunity to meet in small groups with CADIO faculty to work on your own projects. So this is me. I really welcome questions now, or you can email me at any time. And yeah, okay, let's stop there. Thank you. What question?
If you have any questions, raise your hand. We'll bring the mic over so the online audience can hear too. And if you're online, if you have questions, and we do, so.
Okay, awesome. So the first question online is, suppose you want to test if a professionally facilitated support group of same gender peers of childhood sexual abuse survivors is effective for healing with defined healing criteria. There are clearly a lot of potential factors involved. How might one narrow the factors for testing, especially with human subjects in these support groups?
Yeah, I mean, so that's a complicated question, but I think when I kind of pull back the actual question, it's about the granularity of the component that you're trying to test, or the intervention that you're interested in. And that is where this becomes more of an art than it does science. And you have to think about what makes sense. So I'm going to just use an example. I'm sorry, because she's in the room. But one time I worked with Laura Bellows and we made this beautiful conceptual model. And then we took it to the experimental conditions table, and we realized that many of the components that we spent days coming up with no longer worked, because it wouldn't work to do them independently of one another. And so when I think about this question, I think of Laura and how you might need to reconceptualize package of pieces of an intervention so that it makes sense to the person who's experiencing it, balancing that with your research question. So I think that's enough of answering that one.
Okay, and then a second question is, can a glossary of vocabulary terms be shared?
So they, yes, they're on, they're on our website. I do agree, like, there's a lot of terms and a lot of things here. We do try in every publication to really be articulate and specific with them. So I don't have like a glossary per se, though that's a fabulous idea. But all of the concepts are on our website, cadio.org. But so grad students can make a glossary moving forward. Great.
Okay, and then the last question is, I want to make sure I heard correctly. When using most and RCT isn't used, rather it's a factorial design.
So let me be clear that the so most is not anti-RCT. It's just that prior to getting to that traditional 2-arm evaluation RCT, I'm going to run the optimization randomized controlled trial. That factorial experiment is an RCT by definition. It's just a different alternative design to answer a different question than the traditional 2-arm RCT. So because of that different question that we're asking in the optimization phase of most, it is not, the 2-arm RCT is not sufficient, but the 2-arm RCT still has value and can be used in the evaluation phase.
For the person that was asking the question about the glossary terms, because I know it's not up on the screen. So cadio.org, CADIO.
Yes.
.org. Okay.
Yeah.
Excellent.
That word, CADIO.
This is probably a related question. I think it's in the optimization phase. You showed the matrix with the different components and you kind of tested them with the different factors. Are there good examples where like different constellations of components were optimal for some subgroups and other constellations optimal for others?
Yeah.
And just as a follow-up to that, do people end up just seeing what the data show and then following it back, or do they actually use some kind of theory to even anticipate, or a priori, where there might be specific constellations kind of theoretically optimal for certain populations?
Yeah. So my answer is yes. So I would always hope that we would use theory to inform the design of our intervention, and that would translate into the experimental design. So if you were like, I think my intervention will work very differently for people with high literacy versus low literacy, then we would want to be sure we test for that. And so we could, it's the same as an RCT, the 2-arm RCT that you're used to, where we might stratify by that to ensure that we get people of both high and low literacy who experience every possible condition. If, however, you use theory and you thought that the composition of the intervention itself would be different based on those two things, then we would probably need to think about 2 optimization trials to test out 2 different packages, ultimate packages. I will say that because of the way that we have developed interventions historically, we don't really know, right? And so doing a optimization trial where we are thinking about controlling for, measuring all of those different things, and then using that information and the continual optimization principle to come back and think about it again. I think that's probably the most common experience. But I've definitely thought with people about how much do we know that this would be different for different subgroups. It's an interesting question. Yeah. Thank you for letting me share our story, Laura.
So I have a question about your hybrid. I'm
Yeah.
intrigued by that. But so the way that you presented it was that you already optimized the intervention and then you had another component you wanted to test with the optimized intervention.
Yeah.
You also present, the 2x4, 2x5. There's the 2x3 for those of us that are too
Scared
nervous to jump into like the bigger ones.
Yeah.
Could you even take a babier step and do the 2x2 for effectiveness? Or are you only wanting to use that hybrid after you've already optimized an intervention?
So our definition for this hybrid was a evaluation optimization trial. So the primary goal was to determine and do the evaluation phase for our optimization process, right? But tacked on an additional optimization phase. So the priority was evaluation, added on optimization. Like by definition, what you're saying works in terms of designing a factorial experiment, and you could do a 2x2. However, that in my experience would not satisfy reviewers or enthusiasts of most.
So in other words, don't do it.
I'm trying to say that, yes. Because
I get it.
yeah, you're just like, you have more questions that you could answer. And the whole point is to be answering as many things as we can to be efficient with the resources it takes to do these studies.
So it's
One-
really more a supplement and amplifying the work that you're doing versus a starting.
You mean most is a,
No, the
Yeah,
2x2.
the hybrid
Yeah, the hybrid.
evaluation optimization trials. Now, I will say that Billy Nahumshani, who's directs the D3 Center at Michigan, she is coming up with other hybrid designs that put together different like fixed with adaptive interventions or different like intensity of adaptation being tested together. So, we love to come up with names, and so there's hybrid all over the place. And just one more thing that Laura raises is, yes, you could do a 2 to the 3rd, 2 to the 4th, 2 to the 5th. I didn't get into power here because it's usually where I lose people and they get scared. But that being said, you typically do need fewer participants to do a factorial experiment than you would if you were doing individual experiments, right? But you still need participants. And the number of participants that you need does not drastically change from 3, 4, or 5 components. Oh, right. It's a good fact. So take our training, I'll show you how. But there's a pragmatic and practical part of this. And so managing 32 experimental conditions versus 8, which you get out of the 2 to the 3rd factorial, is like a real conversation to have. Unfortunately, we have done a really great job of educating reviewers and program staff at NIH. And so they kind of balk at the 2 to the 3rd factorial for an optimization trial, because they're like, why wouldn't you just do 4? I think there's ways to argue against it, and it totally counts. But the science is advanced if you add another factor. Don't be scared.
Okay, so I've been trying to formulate this question exactly.
Okay.
So I just want to make sure I'm understanding. So on the slide with the factorial experiment.
Okay, sorry,
know,
everybody.
So yeah, so I was like,
This one.
yeah. So is that 64 boxes?
Yeah, but we don't care about the boxes.
We don't, okay. Well, when I saw 64 boxes, and then I imagined 10 subjects in each box.
So it would be 10 subjects per row. Oh, right.
Oh,
Okay,
okay.
so now I've convinced you this isn't
Oh, it's
insane.
completely persuasive. Yeah.
Yeah.
No. Well, so then, okay, so now that means I am misunderstanding something.
Okay,
But then the other aspect of this that I was feeling like just how to carry it out logistically.
yeah.
Because just the managing
Hmm.
16 different conditions.
Yeah.
And then and maintaining random assignment.
Yep.
Across, and then in your child welfare example, you're working in nested structures.
Yeah.
Where you're in agencies.
Uh-huh.
And you have to avoid
Contamination.
contamination. So don't you need an infinite number of child welfare agencies?
Right. So like why I said those were all hypothetical is for that. No, you're right. Okay. So the unit of randomization can be at a higher level than the individual. So it could be schools, it could be classrooms, it could be clinics, it could be agencies. And there's plenty of examples of how that has happened. And there's power and it all works. But yes, I'm randomizing that versus an individual. So in this example, my participants would be randomized to one of 16 experimental conditions. And let's just say my power calculation here to detect a Cohen's d of 0.3, right? I need 352 subjects, but it's 22 per condition, right? So the people get assigned by the row, not by the column. Yeah. But they're all used in the estimation of the column. Yeah. Power, it just goes into a deeper conversation than we have time for today, but we have resources and lots of stuff if you want to talk more about that. Yeah. So by way of hands, how many people learned about a factorial experiment in their research methods classes while being trained? 1, 2, okay, 3. Okay, hey, that's more than usual. It's not something that's taught often. And if we learn about it, it's usually just the 2 by 2 factorial. So sometimes this is a little tricky, but don't be scared.
Kate, thank you so much. Actually, can we go to the slide that had the QR code in case anybody wants to scan that and go to that?
Sorry.
As you said, there's online. There you go. So there you go. If you want to take the Coursera course, QR code will take you there.
And there's plenty of resources on the CADIO website. Also, feel free to email me and I will share everything.
There you go. CADIO.org.
Yeah.
CADIO.org.
Yeah.
All right. Kate Westerfaro, thank you so much.
Thank you.
Let's give Kate a hand.
Turn this off.
That was helpful for a lot. Go forward. The next Talks at 12 is going to be on December the 14th. We're going to be talking about AI and Society Online. So we hope that you can join us for that. You can register over on our website, bctr.cornell.edu. Also, that QR code there has got all of our talks for the rest of the year too. So we hope that you'll be able to join us for that. For those, everybody here and online, thank you for joining us today.